to our webinar. We're going to get started in just a moment. Okay, so welcome to our CIN webinar on navigating operational challenges in sustaining a street medicine partnership. We hope that you will leave this webinar with a deeper understanding of the intricacies of overcoming spoken and unspoken challenges within partnerships between community-based organizations and healthcare organizations. You will also hear about strategies to address operational challenges within a partnership, including staffing, sharing equipment and data, and aligning processes and gaining consistent funding. Before we hear from our speakers today, I'd like to provide a brief overview of the California Improvement Network. Okay, so my name is Vaishnavi Vaidya, and I am the program manager for the California Improvement Network, or CIN. CIN is a learning and action community that advances equitable healthcare experiences and outcomes for Californians through cross-sector connections and spreading good ideas and implementing improvements. CIN is a project of the California Healthcare Foundation, and it's managed by Health Force Center at UCSF. Before we get into it, we just wanted to share a few tech tips. We have everybody on mute except for our speakers, and we will be moving into breakout groups. Sorry, we will not be moving into breakout groups. If you have any tech issues, please message me directly or Marie Hubbard, who is on the Zoom, and we will answer any questions. Okay. Okay, so I will introduce our speakers for today. So on our call, we have John Maceri from The People Concerned. He's the Chief Executive Officer, and Anita Zamora from Venice Family Clinic, who is a Chief Administrative Officer. Okay. So we will get started with our questions. So our first question for today is, can you please describe to our audience the purpose of your partnership and why the partnership was established? John, we'll start with you.
Sure. Well, thank you. And thank you, everybody, for participating today. So we have to kind of go back really about 40 years in time. I've been at the agency 25 years. And when I got to my organization, we had been collaborating with Venice Family Clinic for probably about 15 years before that. We are the People Concerns, a nonprofit housing and service provider for people experiencing homelessness and survivors of domestic violence. And one of the things that we really wanted to increase was access to primary medical care for our clients. And we've operated an access center, which is a drop-in center that sees about 200 and 225 people a day, and really wanted to enhance primary care services there. And so I started to talk with the then CEO of Venice Family Clinic about, how we could expand, that collaboration. There were kind of two things that developed out of that. The first was we were planning for building a new access center. And in that process, we wanted to include medical exam rooms that Venice Family Clinic could actually staff for us. We didn't have that in our current access center. We literally kind of converted a closet into a small exam room that was being used a couple times a week. But we really wanted to build sort of a proper small clinic environment. And then subsequently, we started the street medicine program, which I know Anita will probably talk more about because they really pioneered those efforts. And the idea was that we wanted to reach people where they were at largely, on the streets and encampments. We work on the west side of Los Angeles County, so along the beach and coastal communities there, from Santa Monica up through the Palisades and Malibu. And so we really wanted to sort of craft a collaboration where we could bring those services, to the field, and then have the same providers work in the clinic at the Access Center to provide continuity of care. And that's really was the genesis of the collaboration.
Thanks, John. Anita.
Yeah, so actually when I started at Venice Family Clinic 11 years ago, we were actually working on expanding that clinic at the Access Center that John mentioned. Just to give you a bit of a background about Venice Family Clinic, we're a community health center. We serve a pretty broad area of Los Angeles, ranging from Santa Monica Mountains down through the South Bay. We serve about 45,000 patients per year. We have 19 locations, 3 mobile clinics, and take a very comprehensive approach to healthcare, meaning we have programming that isn't typically thought of as healthcare, such as early head start, food programming. And then, as John mentioned, we have a very extensive street medicine program, which is part of our homeless services. And in terms of the street medicine work, as John said, we are basically doing exactly that. So sometimes it's a backpack, sometimes nowadays it's a mobile clinic, but we're going out into the community where people experiencing homelessness are living or congregating, and bringing the care to those folks. And one of the really, we have about 9 teams right now, again, ranging across our geography. It's been very important for us to be collaborative with a homeless service partner. And the very first team we had was in collaboration with the people concerned, as John said many years ago. But we are experts in health, and we really rely on homeless service agencies to be the expert in housing. There are many reasons for that, mainly because people should have housing and health. And also what it does is it allows us to kind of connect with the person where they're at. They might be more likely to engage in being connected to housing, or they might be more likely to engage in having, a health issue addressed. And a lot of the work takes time. So it does take a strong commitment and collaboration from our teams to work together. And so we did have our early teams working together. They were funded by government and health plan contracts, typically, which is usually the case for our street medicine work. But one of the really exciting partnerships we have is actually with private funders. So Judy and Bernard Briskin Family Foundation, longtime supporters of Venice Family Clinic, came to us and said, we really want to do something to support your work with people experiencing homelessness. And we, thought about our street medicine program and being able to expand that further, and immediately thought of our longstanding partner, the People Concern, because it was such a positive and collaborative relationship. And so I actually have a street medicine team focused in Malibu and Palisades that the 2 agencies work on together. And it's really helped hundreds of people get connected to housing and healthcare. And again, I think what's very unique about it is to have this work supported by a private funder. It is really important to have outside funding to sustain street medicine work. There are changes in the healthcare system these days that are kind of recognizing how costly the work is, because there's a lot of touches. It takes a lot of time, ranging from traveling, but just connecting with folks and having a robust team involved as well. Because we have the clinicians, we have case managers, housing navigators, and we also often have psychiatry with us. And so that immediately, speaking of the partnership, having had that strong foundation, it was kind of a no-brainer for us to continue to work together and apply for that funding to be shared funding.
Great, thank you so much. So, as we know, challenges and tensions can arise in partnerships for a variety of reasons. Can you both talk about the challenge you encountered around developing a funding model that benefits both your organizations and the funding paradigm shift that you all undertook together?
Start or yeah, I mean, I think Anita, touched on this a little bit. First of all, I think that, the challenges involved, we were able to work through this, I think, pretty easily. I mean, partially because there'd been a lot of trust that's developed. We talk a lot about building trust with the people we're serving, and of course that's important. But I think when you're talking about ongoing collaborations in terms of service delivery, there has to be a lot of trust between the partners involved in doing that work. So I think we had a head start. That doesn't mean that it wasn't perfect, because, Anita and I can get along really well, but it's the people on the ground, that are doing the work. And I think we were very fortunate over the years, is that on both sides, on the staffing side, we were really fortunate to have staff who really were passionate about the work and who worked really well together. But I think, the challenges that arose, were really about sort of working out the memorandum of understanding, the MOU, so that it was mutually beneficial. Anita's exactly right. It was Liz Ford, the then CEO, that introduced me to the Briskins, who'd been longtime donors and supporters of the clinic. So, often in our world, we think of ourselves as competitors for funding, but we didn't approach it from a competitive standpoint. It was really a value add. And I think we approached the work in each of us seeing what our strengths were. I mean, the clinic, clearly, we don't deliver primary healthcare separate from the clinic. It's their staff that's doing that. For the most part, we do have some, medical staff, but by and large, in this collaboration, it's the Venice Family Clinic staff that's taking the lead on the healthcare. We're providing the support on the housing and other supportive services that are not healthcare related. So I think everybody, understanding what their roles are, staying in their lanes, but doing that in a way that, brings the best of both worlds together is important. I think on the funder side, we both receive the funding and report together on the funding. So we have our metrics that we report on. Venice Family Clinic has their metrics, but when we submit those, they go in, together when we meet with the funder to talk about the program at the year end. We do that together. So every step of it has really been collaborative. And I think when we have found there are some, Anita's going to talk about some sort of practical operational issues in terms of who uses the van and how do you work all that stuff out. But I think the bottom line is that it's important to understand it's not just doing the work or even being mission aligned, but it's also how you do the work together. I think that's really important to minimize conflict, because we've had other collaborations, with other providers where, we are serving similar populations, but the way we do the work is really quite different. And that can create a lot of conflict. That has been our experience.
Yeah, and to your question about structuring contracts, I think that really often contracts are structured and that reflects the differences in the way we do the work, as John just mentioned. When we as a healthcare agency are thinking about revenue or contracts, we're talking about getting paid per visit or having staff members covered in a certain way. And a homeless service agency might be counting what they're getting paid for a little bit differently. It might be amount of time or caseload. I think actually the people concerned has been very great when we come together and we're, let's say, maybe getting a subcontract for a homeless services team, and we're the healthcare contractor, to say like, well, that actually doesn't work for us. Like with our structures, they get paid the way that this agency is paying the dollars flow, because we're just not organized like that. And been able to have the people concerned kind of go back to the table and help discuss that. I mean, even the street medicine work that we started together, years ago was new. And since then, obviously there's a lot more street medicine around, but some of that work together really influenced I think how programs are structured going forward. Does it make sense to have a nurse do this work, or a physician or nurse practitioner? Who are the best people on the team, and how should things get paid? And we've seen more flexibility from the contracts in contracting agencies, and how we do the work going forward as a result of that. And we definitely, as John said, really deferring to others' expertise. I think it's been great for the teams to get together and learn a different way to approach things. One key difference that's very different is when you talk about homeless services, social services versus the healthcare model. Healthcare, we don't do case conferencing. In that hour, you're talking about those 4 or 5 patients. We could be seeing 10. It's just a very different approach. But I think we've all learned from each other in how to best meet the needs of patients, and when to bring in the expertise of the clinician, working out the logistics of the timing of the meetings and what cases that you need the healthcare perspective on. And that's been great. But John mentioned about some of the practicalities. Out the gate with this shared program, with the private funding from the Briskin Foundation, we of course needed to be able to measure our impact, and we count things very differently. We also are not on the same system at all, which is still a reality. And we needed to come to agreement about how we're going to record things. How are we defining an encounter with a client or a patient? From a healthcare perspective, there actually has to be a certain amount of discussion and diagnosis and those kinds of things if we're actually going to chart it in our system. But we know that a lot of the work that's involved in street medicine is some initial we might call touches, and building those relationships, planting the seeds. That might take a few times of the team interfacing with the patient. So we talked about how are we going to have some kind of shared documentation system to capture that. It was the focus more on housing, or was it on health, or was it both? So actually the team, I think our support of the partnership from a leadership standpoint sets the groundwork for the team to be able to work those things out. And they ended up tallying everything manually, entering in an Excel spreadsheet. We're still kind of doing it that way because we did need to, report jointly on the work that we were doing together. There also became some logistical issues that when we go out, we're going from, the west side to Malibu Palisades. People might be meeting there. So there's different configurations of the team that goes out at different times. We actually had the vehicles at Venice Family Clinic to go out with the street medicine team. But it was challenging that it always had to be one of us who was driving, either because the clinician was going to meet them there, or the medical assistant that's part of the team was going to meet them there. Or sometimes the housing team, it makes sense for them to go out by themselves. So we actually, sort of simple, but you also, again, as where trust comes into account, we made it so the people concerned, staff, could drive Venice Family Clinic vehicles, put all the insurance in place. There's a little agreement about it. And so again, it's just sending the message, we are a unified team, we're doing this work together. These are our shared resources.
Great. John, do you have anything to add about any tactics that you use to steer your partnership in the right direction and overcome some of these operational challenges?
Well, I think Anita's, has touched on a few of them, and I would just, underscore that I think, good communication is really important, and trust is really important. I mean, the clinic has been, one of our strongest I would say actually our strongest collaborative partner over decades. We have a lot of collaborations, but none of them work as well, as this one. And, why is that? It's, a lot of it is the people involved. A lot of it is the shared values, I think, of the organizations, not just in terms of mission alignment, but again, how we do the work, our philosophies. I mean, need to use the example of, the van, which seems like a little thing, but actually on a street-based team that's going to parts of the county that you can't get to without, using transportation, that's a huge deal. Being able to, because there's different disciplines on the team and not everybody on the team needs to be involved in every encounter, because sometimes the teams will decide that it's going to be the outreach, folks that are going to take the lead today, or it's going to be the housing navigators because they're at a place where, moving people indoors is really important, or it's going to be the psychiatrist, or, however it's going to be configured, but to be able to work that out so it isn't a tug of war, that it just is sort of natural and seamless. And so there's got to be good communication. I think both organizations have done a really good job in encouraging and trying to support and empower the staff to work together and to make those kinds of decisions. So I think that, that has been really, helpful in terms of, navigating some of the things that invariably, team members change. We've been doing this together a long time. So you have, new members coming into the team and trying to, integrate them as well. But there's always been, a high level of communication and transparency. So when we've encountered challenges, we're able to talk it through and work through it pretty quickly. I mean, I can't think of any instance where we've reached an impasse where we haven't been able to figure it out.
Yeah, I agree. And I think it's an orientation of maybe not doing the thing that's the simplest for our own agency, but really for the benefit of the partnership. I mean, I mentioned how we have to report data for a while, and I think it's a little improved, but we basically had to ask people concerned team if they could do double data entry. I mean, some places, who wants to do double data entry? Both teams, even within the whole or their own organization, would say, no, I don't want to do that. You all do that work. And they're gracious enough to do that, and like as they sure use our vehicles. And I think the communication, like I said, it's established kind of at all levels. I mean, when we were expanding the clinic on site at the Access Center that we talked about earlier, we were having just kind of nightmare bureaucracy issues with getting our network in place so we could access our electronic health record at with a faster speed. And we're just having a lot of trouble. I was able to just call John, and John's not gonna put the network in place, but I could call John and say, hey, here's what's happening. And he was able to then facilitate having the right people be connected to be, and the message again, like, this is important, let's move this forward. And even with the shaping of the street medicine team for Malibu Palisades, having our team involved in the development of it. We have a homeless services team, we have a director of homeless services and clinicians, robust staff, and same thing, at the people concerned, how do you want this to be designed? So it's established early on that there's sort of input and involvement across the teams with the work that we're doing together.
So both of you spoke about this a little bit, but what 1 to 2 pieces of advice would you have for other organizations who are entering into similar partnerships or encountering similar challenges in operationalizing this work?
Yeah, I mean, I think, not to sound like a broken record, but, I think trust is foundational. I think in all of our work, right, collectively, I imagine everybody on this call, and you're thinking about, your own work and your partnerships, that's, that it works best when there's a level of trust. And I think, really approaching the work from a problem solving, and a can-do perspective. Anita said it earlier, and I agree completely. A lot of times in successful collaborations, what's doing what's best for your organization may not be best for the collaboration. So, the idea that, right, whether it's double data entry or there may be other things that, one or the other partner is taking on to say, hey, this is our contribution to the collaboration. Yeah, it may be a little bit more difficult. When we worked out in the early days, the reimbursement, piece, we were very clear that Venice needed to get paid what they needed to get paid. And if it didn't fit into the construct of, you know, how the contract was set up, we made it work and we figured it out so that, you know, we both came to the table feeling like our, you know, both of our needs were being met. So, you know, and a lot of times I think there's, especially when subcontracts are involved or money's involved and when, you know, money's tight, the natural inclination is to say, well, you know, this isn't going to be good for my organization. And I'm not suggesting that anybody go bankrupt in collaborations. That's not what we're talking about. But I think that the ability to be flexible and say, hey, you know, this is fine. I'm more than willing to, you know, make this, you know, this adjustment. And then I think the last thing I'd say is really being clear about what your strengths are and what you bring to the collaboration, and really reinforcing that, you know, that this was not about, you know, the people concerned ever wanting to be a primary care provider. That's not our wheelhouse. It's, you know, the clinic does that well. They're a great partner. We want to do everything we can to enhance and support their work. And the benefit, you know, to the people we're serving is great. And the same was true on the other side, that there wasn't, you know, everybody understood what our role was, and there was no desire to sort of overtake that. And I think when you have staff working side by side that are all competent and confident in their abilities, that has, you know, made it work over a very long period of time.
Yeah, I mean, I'm probably just going to say more along the lines of what John said. I think that point about really recognizing and valuing our own and each other's strengths is very important. You know, homeless services are a big part of what Venice Family Clinic does. We were some, you know, the early folks really focusing on people experiencing homelessness, but we recognize we are a healthcare provider. That's where our expertise is. We have said if it was ever needed, we might get into, you know, more the housing business, right? But we have very strong partners, and you know, that's why we have these collaborations. But you know, just to illustrate that, this, you know, the new ECM programs or enhanced care management programs that are now coming through the Medi-Cal, we have one of those programs, and one of our responsibilities is to do housing navigation. We immediately did not try to, it wasn't, let's do this ourselves. Immediately it was like, let's ask the people concerned if we can contract with them and have a housing navigator, not just like our own to help us, but can they actually work at Venice Family Clinic and be part of our team? So that, you know, that's the first thought, right? The expertise is there, and they're of course willing to say, sure, it'll be our staff person, and it's okay if they, you know, work at your location. It's those kinds of, you know, again, it's this partnership is developed over years, and we collaborate in many different ways. I think it's also very much of it showing up at the table. Whenever we have, let's say, coalition or collaborative, we're trying to bring together agencies. We had a group called Westside Health Access. We asked, you know, John and people concerned, can you be part of this? You know, it's about trying to make sure there's appropriate access and services for, you know, people experiencing homelessness and others, and to show up for those, to like John said, you know, our CEO introducing the people concerned to somebody who's our funder. It's not a competition. We're all doing this work together. And we've had, you know, what we have, we all do exploration, right? You know, we've gone to look at sites that would be good for clinics, and then there might be some potential housing component. Hey, let's call John up and see what he thinks about it. And we've also had conversations about endeavors that maybe didn't turn into anything because it wasn't quite in one of our wheelhouses, but at least we're kind of coming together and you know, being thought partners too in that work. I think it's very important. And, you know, we did talk about this again, but really encouraging and supporting the relationships of the staff that work with us. You know, John will always answer his phone. And also, you know, sometimes it's better to try to get the teams if they're having some issue, right? Whether it's a coordination issue, collaboration issue, we're there to support it. But, you know, I've always made a big effort to try to, you know, let us know, talk to your colleagues, pull us in if you need to. And really, honestly, it's been pretty amazing how well people work together because that trust is there. But it is important for us to foster that, and that the dialogue isn't just among, you know, the executives or the top leadership.
Okay, great. Thank you both so much for sharing your insights. We now want to open it up to questions from the audience. Feel free to raise your hand or pop a question in the chat and we will read it out to you. And you can just come off mute when we get to it. So let us know if you have any questions. Okay, there's a question in the chat. How have you dealt with different types of data platforms between CBOs and a medical team? From John Haler.
Do you want to start with that one?
Sure. I mean, that's definitely an important consideration. I mean, especially if, you know, in healthcare, even we can't even between healthcare agencies sometimes share information. And you know, we talked about this a little bit, but that was one of the main challenges with the street medicine teams, which is especially when we start to have the obligation to report jointly. How do we capture that data? And in particular, we were wanting to report on outcomes as well. So we have to have it know, well, what was the housing outcome for this person, as well as what's the healthcare outcome for this person. And really a very low tech solution, unfortunately, which is, you know, we had to, we sort of developed our own kind of tracking spreadsheets and, you know, asked the people concerned, even though they had their own documentation system, it's going to do double entry and also document and share with us. But a way we resolved it, though, I mean, going into it, was agreeing what we were going to be reporting on in the first place, so it wasn't down the line and trying to slice and dice data that had been documented differently. We also have had over the years, you know, there's different databases, if you will, for housing, getting people connected to housing over LA County. And initially, healthcare agencies didn't have access to it, although homeless service agencies did. And there were entities like the People Concerned and others that we work with who actually advocated for us to get access to, because if our clinicians are out doing street medicine, it's really good for them to know that they're, you know, the patient's already entered into the system, where they are, what else do they need, especially because we're often the ones to sign off on, you know, clearance for shelter, those kinds of things, or what their disability status is. So I'd say it's not, you know, we haven't found a solution. Oh, you know, our systems talk to each other, but it's more of a commitment of sharing information and giving each other access. John?
No, I would agree with everything you said. You know, we sort of developed our own workaround. It's not elegant, but it works for us. And because we were able to set it up in advance based on what each of us wanted and needed to report, it's actually worked out, you know, pretty well. It's not as seamless as being able to just do a single entry into, you know, one database, but it's worked out okay.
Okay, we have a few more questions in the chat. So does Venice Clinic also contract as an ECM provider with LA Care or HealthNet? And how have you coordinated with the local managed care plans? If so, are you screening and billing for ACEs?
Mm-hmm. Yeah, so Venice Family Clinic, we do have an ECM program. We're contracted with LA Care, HealthNet, Anthem, and we'll be starting with Molina soon. It kind of comes a different route, not to get into the contracting part of it too much. It's, you know, that those are our plan, but, you know, it's a direct contract with them. Generally, the requirements are fairly aligned, but there are also individual requirements for each one. And I think what we really see is ECM is very complementary to obviously our work in the clinic doing and seeing people experiencing homelessness, but our street medicine team, I know this isn't exactly what you asked, But our street medicine team has actually recently been kind of proposing doing some pilots for the ECN team to be able to join as well, because you get sort of the more in-depth case management, or to and they've actually developed kind of pathways to connect back to the ECM team, whether that's the nurse case manager, care manager, because just like out in with homeless service agencies, we're often touching the same folks, just in different places. We do screening and bill for ACEs, and we are federally qualified health centers, so the way we bill is unique to federally qualified health centers, but we do ACEs screening as part of our routine kind of screening for folks. So that's screening for adverse childhood events.
Okay, how does street medicine intersect with street psychiatry, and how does that work across, draw across resources from both organizations?
So psychiatry is part of the street medicine team, and it was built in from the beginning as some of the team members are also, they're not psychiatrists, they're licensed mental health clinicians. So that's been part of the team mix, and we added psychiatry several years ago. So from our perspective, the way it works is the people concerned, we contract with psychiatrists to work with the street medicine teams, and those are billed through our LA County Department of Mental Health. So we have a contract with DMH that allows us to bill for the psychiatry portion of the visits. That's how it's structured from our side.
Yeah, it's also part of our street medicine work. So not all of our street medicine teams are a partnership with the people concerned. Psychiatry is always a hard resource to come by, in the clinic setting as well as street medicine. So we don't have psychiatry on all of the teams, but as John said, it's really important to have that kind of behavioral health perspective in some way. We don't usually do, sort of standalone street psychiatry. It's kind of more part of the robust, healthcare. But we do have psychiatry folks going out with the street teams.
And then there's one question: how do you train each other's staff about how to work with each other's organizations? What's the onboarding process for staff working within this partnership?
Starting.
Yeah, it's interesting. It's a great question, especially if you want to kind of institutionalize partnership. And I think it's probably an important question for, like we mentioned, our, the CEO who was here when John started, who only recently retired, is obviously carrying a lot of the value of the partnership and kind of, spreading that. But we do, as an organization, we're very oriented to partnership. So it's not a formal, like, okay, everybody, orientation time. This is how we partner. This is who we partner with. But we do orient to, what our services are and the work that we do. And we always talk about that our street medicine is with the partner agencies. It's not, we're just doing street medicine. So that's part of it. And I think also for the teams, they're doing, obviously the street medicine teams are always done in partnership. So they're learning that as well. And from each other, the leaders of the team, as well as the other staff. One of the things that we actually have a curriculum for street medicine, and part of that curriculum, so we can have other, whether it's residents or other med students or anybody, kind of ride along. And a big part of what we're sharing in terms of success and what are the protocols is the importance of having the housing component and the behavioral health component as well. So that's really the model we feel like is successful. So that gets passed on to folks. But when we have new people oriented, say new clinic manager, director of operations, there's a whole checklist of sort of what they rotate through, ranging from the call center just to see what it's like for somebody to schedule a visit, to shadowing at the front desk. They do ride along with our street medicine team as well. So it's sort of twofold. this is an important service that we provide, and this is how we, how it fits with what we do, but also the seeing firsthand what the collaboration is.
Yeah, and I think just in terms of the actual staff working on the teams, that a lot of that training and onboarding is done directly by the leadership of those teams. So our staff who are working on those teams are responsible, as they would be in any of our, other programs, for making sure that the staff understand and are oriented towards their specific roles on the team, how the team operates, who's doing what. Who do you go to when you have questions, all of that. So that's very much field-based and very specific to the onboarding for that particular street medicine team.
Right. So we have a question in the chat about additional operational or logistic challenges. So what are some of the operational logistic challenges and how did you navigate those? I think someone mentioned some insurance issues for using the van together and EHR access, but was curious about any others.
Well, when it comes in terms of the street medicine partnership, our team is really good at working on day-to-day challenges together. There are things that come up, that I'm aware of, but they're not so challenging that we've had to, have a summit around it or anything like that. How are we putting gas in the vehicle and making sure it gets, those are really practical questions. But if the people concerned staff were the ones who had the vehicle and need to fill it up with gas, how are we making sure that Venice Family Clinic pays for it? It's things like that. I think it's also, I kind of mentioned it earlier, kind of the culture of just the, social services versus healthcare and how we operate, when it comes to the time for case management. But even, for us in the clinic side, you're out doing street medicine, maybe in the morning, and in the afternoon, want you to come back in the clinic setting. So what is just, how do we make sure we're giving enough time to both of those activities, especially when driving is involved? And again, working that out collaboratively, because there's a time they want to do case conference, and maybe our clinician is also consulting with the homeless team on a couple of cases, but we also need them back in the clinic setting to see folks too. So they're not in a way unique challenges, but they're the kind of day-to-day challenges that we need to make sure that we're navigating together. And again, with this orientation about what's good for the collaborative, not just what's good for the organization.
Yeah, I don't really have anything to add. It's, exactly right about that. A lot of it is just the sort of day-to-day operational issues that you kind of work through, but I don't think there's anything that's been, completely unique to this collaboration.
How do you manage client privacy, and do you utilize ROIs to share and obtain information?
So yeah, I mean, for the teams, there is signed informed consent for us to be able to deliver, joint care. We don't obviously have access to Venice's, electronic health record system, but in terms of the teams actually working with clients, because they are shared clients. So we always want to make sure that we have, signed in consent forms when there's ever any exchange of information, which is frequent because the teams are there together, doing their work together.
Yeah, and fortunately, over the years, there's been a little bit more clarity on, about what information can be shared with this kind of work. So if you're, two straight ahead healthcare agencies, you can share for treatment payment operations, right? And then it used to be this kind of question mark or gray area, but well, what about for case management or housing? What can we share? And there's been some clarity, kind of in the rules or regulations about that. So, this is part of the patient or client's care. We can share the information that's relevant to those patients among us, so the teams can appropriately collaborate.
And then there's a question in the chat about how are you billing for community health workers? If so, has that process been challenging and how?
That might be a question for us as a clinic, although maybe it's relevant to you, John, I don't know. So federally qualified health centers can't actually bill for community health workers, even though it is a Medi-Cal billable service. Federally qualified health centers is a little bit different. So in that sense, it is challenging. There's some advocacy around that because community health workers are actually, very, valuable to the teams, and also some getting creative, just knowing from my peer clinics, maybe contracting with another agency that provides community health workers. We still do use community health workers, and we have intern programs for community health workers. But right now we can't bill for them separately.
We don't have any community health workers, and so we're not billing for them.
Okay, any other questions? And feel free to come off of mute and ask a question as well to the speakers. Okay, there's a question. Are community health workers not able to bill through ECM?
So ECM works a little bit differently than other services. It's sort of a separate contract. So yeah, we can bill, for us there, but we refer to case managers, but they're effectively the same as CHWs or care navigators. There is some billing that can be done. ECM contracts work in two ways. Sometimes it's sort of your fee for service, and based on that, who's providing the service, what's the nature of the service. So is it a CHW or a nurse or a clinician? That's you're kind of billing for units, if you will. But some of the ECM contracts are actually like a per member per month. So just care for the patient. We certainly report on the encounters we've had, but the billing isn't really impacted based on who's interfacing with the patient.
Any other questions about the partnership or any other insights from the group? Okay, well, before we wrap up, John and Anita, what are some final thoughts that you want to share about this work? I know you've both been doing it for a very long time, so any final insights or thoughts about how to be successful in building this and sustaining this partnership?
Yeah, I mean, we've covered a lot, and I know I'm going to sound like a broken record yet again, but I think our experience, we've had a lot of collaborations and still are involved in a lot of collaborations in different areas of our work, and the most successful partnerships really have been those that have been sustained over a long period of time, based on all the things that we've talked about, trust, open communication, shared values, and really the approach to the work. And I think obviously we've been very fortunate to have really good staff working on the street medicine teams over the years. And I think at the arc of time, we have a few staff that have been at it. I'm on the Venice Family Clinic side. I mean, Dr. King has been there from the beginning and has really been the guru of street medicine, and has really brought a lot of other physicians into the field, which is exciting to see. And our experience has been that, yes, we feel very fortunate and that we picked a good partner from the beginning, and we nurtured those relationships. But you have to keep at it as well. And I think the ability to be able to kind of navigate through when you get bumps in the road, and they occur. I mean, even with the best staff and the best collaborations. There are challenges, but you know, our experience has been that when everybody approaches the work from the same perspective and really, you know, the North Star is what is best for the people that we're serving as opposed to what's best for my organization, it tends to work out really well.
Yeah, I mean, I think that was very well said. If you're considering, you know, partnering with another organization, you know, to really think about it synergistically, not just, you know, there's a lot of agencies we work with and we might call them partners, but to really have a collaboration, not just about finding an agency and working with them because they're closing a gap, but really what you can do synergistically. Because I think we've become stronger agencies, I think, because of our collaboration with each other and the perspectives that we've learned from each other. And, you know, we are just as strong of an advocate for housing as we are for health. And I think a lot of that comes from seeing the work that the People Concerned does and the work we do together. And once you have that, you know, you can actually really accomplish much more together, and continuing to invest in it, you know, I think over time is, you know, very key. It's just as important as the work that, you know, we're doing as on our own as an agency. Like, this is really an integral part of who we are, and it's important to invest in and maintain and nurture that relationship.
Great. Thank you, John and Anita, for making the time to share with the CIN community about your collaboration. It was really great hearing from both of you. With that, there is an evaluation that must have popped up on your screens. If you could take just the next 2 minutes answering those 2 questions, that would be really great. It helps us make these offerings better. And otherwise, that wraps up our discussion today.
Everybody,
Thank you.
take care.
Thanks all.